just in terms of my background, I work pretty closely with the RXP movement in California as part of the board. So coming some perspective from that. So, you know, every state is going to have different regulations in terms of what you can and can't do. Louisiana and New Mexico have been around the longest, have negotiated that probably more thoroughly. I know Illinois had to be more restrictive on certain levels just to be able to get it passed. So one of the things I do know pretty strongly is that the thing that is going to be the most important that for gaining prescriptive authority in states is to know what we should not do. And so knowing specific medications and all the details of them is not nearly as important. In fact, it's really not important at this stage so much for you. It's about what not to do. For example, to not give a MAOI when you're on another medication, or to not ignore a rash. So these are the things that the medical community, particularly the psychiatric community, is looking at us for, that we basically, they're afraid we're going to kill patients. So we got to look at the things that really are not going to kill patients. And I understand the argument that I think it was Arnold was making about blood pressure, and it'd be great if we'd be able to, know all that an internal medicine doc would know about blood pressure, for example, or if we're in a rural state, a rural area where there is no other medication. But if we start talking about things like our desire to be able to regulate people's blood pressure rather than sending them to the primary care, I think that's where we're going to be in danger of not getting prescriptive authority in states, because we're trying to take it on all ourselves. So my training is with integrated primary care, is really to figure out how we can collaborate with others to know when it's really beyond our scope of practice, and to refer out, as well as just protecting our own liability. And as Dr. Papp said, some psychiatrists are going to be more comfortable at prescribing some things than others. But Dr. Papp, for example, who is far more medically trained than most psychiatrists for various reasons, would refer out for something like that. You monitor the patient's blood pressure, you work at changing medications in order to help with the blood pressure in terms of your own perspective, but in general, to try to refer out to somebody that is going to look at the whole scope rather than yourself. So I think it's frustrating for everybody to know that we have limitations, but the reality is for the prescriptive authority authorization, it's going to be important we really understand our scope of practice. Does that make sort of sense the way I described it? And if not, please contact me. Please contact me. My point is to point out the difficulties faced. Yeah, and difficulties faced. I mean, I would say there will be a difficulty, for example, even with psychiatrists, when they see a patient with, blood pressure that's going up and down, and they're going to have a similar, issue trying to get their patient to see a primary care, or if there's sleep issues, to try to get them to, a sleep study. So it takes like 6 months here in San Diego from some of my patients to get a sleep study. But just like I said, I think it is important for us to really understand how important it is to collaborate with others. So, okay, let's move on to side effects. So a lot of these things have been covered in little detail and things, but this sort of puts it all together. Again, we really need to know when these side effects are dangerous, and what we would not be prescribing in conjunction with others, for example. So you can see these side effects emerge way before the therapeutic effects, and in fact, a lot of them are ones that will be there temporarily and then subside. And clearly, each one is going to have its own little subset and unique to it. But we don't want to confuse symptoms of depression with the side effects themselves. So sometimes things like flattening effect can be a side effect of the medication. We don't want to think of that as depression. And this significant dropout rate due to side effects, you'll see it all the time. Tricyclics is clearly the highest. And it's one of the reasons that people are are really dropping out. So here are the most side effects of SSRIs, not serious side effects, but the non-serious side effects. You see sexual dysfunction, drowsiness, weight gain is the top doers. And I would say from my perspective, the things that most are complained about are the sexual dysfunction and the weight gain. And the reasons either people won't take medications or what they're experiencing. So I'm just giving a general idea first of these commonly reported side effects. So Dr. Papp talked about the tricyclic side effects. The sort of drying mouth is really benign, but orthostatic hypotension is something that you would manage with behavioral things, for example, but the prolonged QT interval is certainly something to consider in some, particularly in some of the medications over others, but it's an extremely dangerous medication when taken overdoses due to antimuscarinic toxicity. So this is not a medication to prescribe to somebody who's suicidal unless it is controlled by somebody else. So Dr. Papp talked about the MLI serious side effects, and for some reason, it was put on one of our, as one of our objectives for this course. That came from the higher ups, and I think it's because of this basic issue is that we really need to know when some of the very serious side effects we have to be careful of. So posted on Moodle is a list of foods. We have to, of course, educate our patients about them. But there are some recent articles that I've been reading about there's sort of less tyramine in our foods these days to be wary of, and so there's less worry about it than there used to be. But MSAM, for example, has less interactions in others. So if you want to use an MAOI, that's going to have less possibility. But just like other medications that are more difficult to prescribe, you want to think when you're first learning to prescribe, you're going to have, in your arsenal, some basic medications you know pretty well. So you're going to know escitalopram, and you're going to think about knowing some medications really well. And these are the kinds of things when you start thinking of an MAOI, it's going to take a long time before you feel really comfortable prescribing those in the real world. I think that that's where even collaboration can be helpful. That in cases that are really severe, perhaps early in your career, that would be some. If you're going to prescribe, would be something that you would prescribe out. So here are the origins of these side effects, and I'm not going to go into great detail about it, but really there can be a very complex interaction between neurotransmitters and other systems of the body where one's affecting the other. So the antihistamic side effects are going to be more weight gain and sedation. Mirtazapine is well known as a weight gain. Most of the tricyclics are going to be more weight gain. Paroxetine, that's Paxil, trazodone. These are the antidepressants. I'm not talking about the antipsychotics, which have their own profile, which Dr. Papp talked about. The catecholaminergic side effects, you're going to have the pro and the anti. So you're going to have sort of more activation with the pro catecholaminergic side effects, agitation. So the medications that are going to be higher in this are bupropion, stimulants, desipramine, milnacipran, and venlafaxine. And then the catecholaminergic, it's going to give this low blood pressure, this orthostatic hypotension, more sedation. So the list here that has higher are trazodone, nifazodone, and most tricyclics and the MAOIs. You're going to be careful about the low blood pressure end of things. The anticholinergic symptoms are all that drying sort of stuff. blurred vision, memory problems, so this cognitive dulling that you'll see in people. And there are these new studies that are correlating with dementia. There's argument in the community about how much that really is an issue. But in general, I try to guide people away from anticholinergics if they're older, just because of the memory issues, and certainly if they're doing over-the-counter anticholinergics, I'm very careful about talking about it. So there's going to be problems, particularly if there are things like urinary retentions and things like that. In the older people, so you want to be particularly careful in older populations. So higher are going to be the tricyclics and paroxetine. Some of these medications are actually used for their side effects. For example, some of the tricyclic antidepressants, enuresis is treated, but overactive bladder can also be used. So their side effects in some cases are what you're looking for. So the dopaminergic side effects, the pro are going to be more likely for psychosis. So you're going to be careful if you've got a psychotic depression. This isn't something you would be thinking of adding first. So that's psychosis, irritability, aggression, insomnia, and then antidopaminergic. There's going to be more akathisia, restless legs, and so the antipsychotics would be a part of this, or agitation. Okay, let's do a bit.
No, I think you skipped the serotonergic.
Oh, I skipped one.
Yes.
Oh, go back. Sorry. Serotonergic, which are clearly the ones we're talking about most. So you probably learned in your the classes that most of the receptors, there are more receptors in the gut than the brain. So clearly the GI is going to be affected. So, some sort of GI distress, these are sorts of side effects that generally will go away within the first month in general, not always. And then you can always add things. We'll talk about what you do about them. But the effects are really caused by the peripheral effects of the serotonergic action, not that in the brain. So anxiety activation. So if you see anxiety activation, you're going to be aware of serotonin syndrome. And I will, again, talk about this serotonin syndrome, because this is the kind of thing we really want to know. You want to know that you know this really well. So you don't want to cause serotonin syndrome. So another side effect would be apathy, emotional blunting, and inability to cry. And weight gain and sexual issues. So you want to avoid any medications, other medications with serotonergic action, which can be a wide variety of medications, which I will go over. So we did this one. Okay, so let's take a little quiz on weight gain. So the question is, when is weight gain considered a side effect of an antidepressant medication? A, when any weight is gained after taking antidepressant medication. B, when weight gain exceeds the amount of weight loss attributed to depression. Or C, when weight gain exceeds 10% body weight at the time of the prescription. Okay, so I would say of all the quizzes I've given, yeah, this was the lowest score by anybody. Only 2 people got this right. The answer is B, when weight gain exceeds the amount of weight loss attributed to depression. So I'm not going to, oops, we got 3 people. I'm not going to go any further into it, but that is the definition of weight gain due to an antidepressant, when the weight exceeds the amount of the weight lost attributed to depression. Tricky, huh? Okay, let's look at what to do about it. So when you prescribe the medication, you're going to think about how much you're going to tell the patient about the side effects. So this is tricky sort of stuff. So you're going to talk about the most potential likely side effects with people. But if the patient is really anxious, if you tell them all the side effects, they're going to have all the side effects. So you want to be careful about how much you're going to tell them about, and you're going to probably explain to them, because they're very anxious, you don't want them to talk about it, to talk about all of them. And I actually steer people away from going on the internet to look up all the side effects. Choosing the right medication is going to be very important about it, explaining that there is medication benefit, but there is potential side effects and what the risks are, and that some of these side effects are going to go away earlier, like the headaches, but weight gain is a long-term side effect of antidepressants. And I cannot stress this enough, the need to contact you should that they add any other medication, over the counter, prescribed, or herbal. Herbal is I think, I mentioned a case of where the person was taking, I can't remember what, spirulina, and it ended up with a manic attack. But you are always, 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 always going to talk about the potential serious side effects, i.e. those black box warnings, which I'm sure you've had in other classes. So if the patient is having side effects, you're going to figure out which is a side effect and which is that just part of depression. So emotionally blunting versus anhedonia are different things. So early side effects, you're just going to be patient about it. Things like headaches, they usually go away. But if these side effects continue, there are ways to change it. I mean, there are a number of patients that I've had that come in and they're taking their antidepressant at night. And I say, well, have you? And they can't sleep. And I say, well, have you tried taking it in the morning? And voila, they're cured of their insomnia. So you want to think about changing the timing of the dose, either night or day, so time of day, or potentially splitting that dose. Just their eating habits can change it. And then that good old STAR-D thing, reduce, switch, or combine. Now you can add something to reduce the side effects, like Dr. Papp mentions, but ordering the labs to really see what's going on is going to be essential for a lot of things. And you're going to think outside of your treatment, meaning you're going to think about referring out and things that also may be going on outside of your own medication treatment. Are they taking something else beyond what you know? Okay, is there attendance poll? The attendance poll will be before we break for lunch. We haven't broken for lunch. I'm going to see how much I can get through this before people completely lose attention. We have 1 minute. I don't know what that means. Okay, so here's the attendance poll. And then it says, what if there was no weight loss? So I'm not.
Then any gain is
yeah, so if there was no weight loss due to the depression, then any weight gained is weight gain, right? So it's as a side effect, it's the difference between the two. So no weight loss, then it's anything that they've gained afterwards. Okay, so activation is akathisia, restless legs and agitation, aggression, irritability, anxiety. As I said, I mentioned that you've seen this other in classes, but it's going to be something. So A is correct. My poll isn't up anymore. I'm sorry. I don't know at this point. No, the answer I told you was the one that was correct, which was B. So the difference between how much, we can talk about it offline if you want to. So activation, we're going to break for lunch, but I'm going to go try to get through some of these slides first. I had sent a message that said we're going to break a little bit late. Okay. Activation is going to present in hours to days and usually diminishes 2 to 3 weeks. and it's complex interaction between the serotonin and the dopamine, serotonin increasing and dopamine going down. But if you have a fast increase, it's going to be more likely to get that activation. So the medications that are going to be higher activation are bupropion and stimulants, including caffeine. So look at their caffeine intake, but also possible with some of the SSRIs, especially fluoxetine. So in general, I think fluoxetine is not a good first line for people who are sort of edgy. The action to do is that you can do a sort of low dose tranquilizer the first month, hydroxyzine, gabapentin. There are other things that are sort of calming for people that you can add, and then you can remove them. But if it doesn't increase, switch if it does not improve, it's supposed to say, because people feel really uncomfortable in this state. So you're going to have to switch them off if it doesn't improve. So switching is different than activation. So switching, this is a warning sign of bipolar disorder. This little kindling theory is that you can have some cycling, but then if you get a switch, they can go into a full threshold of the disorder. And this is going to be about 2 to 4 weeks of the antidepressant therapy. So it's not going to start right away, but it is something that you're going to rethink your diagnosis pretty quickly. They have agitation, insomnia. So as we discussed before, even if there's a hint of bipolar, you are not going to use that MAOI or tricyclic and then caution with anything else, especially fluoxetine. So the best action is, any sort of doubt whatsoever, bupropion is going to have the lowest potential for switching. And then you're going to add a mood stabilizer before adding an antidepressant back in. You really need to stop the antidepressant or reduce it pretty rapidly if there's a switching going on. Sedation, the higher, one of the highest medications is going to be mirtazapine. At low doses, so mirtazapine at low doses is sedating. Over 7.5 milligrams is less sedating because you get a norepinephrine effect. So low dose mirtazapine is what is sedating, as well as doxepine, trazodone, paroxetine, and some of the tricyclics. So you're going to certainly avoid those. You change the timing of the dose, split dose, reduced dose if you need to stay with that medication. Switch medications, again, you're thinking STAR-D. You can also add something like bupropion or a low-dose stimulant, particularly the first month of the medication. So modafinil is a great little drug. I don't know if it's discussed in other classes, but much less likelihood of abuse. And then, of course, all the behavioral stuff we do. So insomnia is a pretty common, I've lost my.
I apologize, doctor. How far before we go for lunch break? It's usually at 12 o'clock.
I know it's usually at 12. I had sent a message that we're going to be a little bit later because I want to get through just a little bit of this. Okay. So at least until a quarter after 12. Okay. So insomnia, the higher dose of bupropion is going to be, we're going to go about 10 more minutes. I don't know if people are not getting my my chat room. Not getting my chat room discussions when I told you what time we were going to break or not. 12:15. I'm just going to go a little bit longer in terms of, so it's 10 minutes. It just does not respect our time. So I was never told that we had to break at 12 o'clock. If that's the rule, then let's break. So we'll come back in 1 hour. We'll see you in an hour.